smile design and facially generated treatment planning is all based on how you mount the upper to a photo. It's all about like the maxilla and the photo lining up. The lower jaw is just, it's going to be moving around. You just got to figure out how to interdigitate those accurately. But the aesthetics and stuff all comes from mounting the maxilla, the teeth to the maxilla, and then mounting those properly so you can look at the face correctly.
Hello, Dr. Sven and Daniel. Thanks for coming together today. We're going to have a fun discussion on bites and occlusion. And Dr. Sven, you said a few minutes ago that sometimes it can be like a religion and a dogma. And then if it's religious, you're right and everyone else is wrong. But there are some fundamentals and some definitions and some common anchor points in how we approach the bite and occlusion. And I wanted to spend a few minutes establishing some definitions, and then we'll jump into a case and talk about how you manage occlusion, how Daniel is able to manage occlusion. So thanks, guys, for being here. So first up, Dr. Sven, walk us through what maximum intercuspation means in relation to talking about a bite.
Yeah, so maximum intercuspation is a tooth-centered way of looking about how teeth interact. And so maximum intercuspation is looking at the shortest distance between the upper teeth and the lower teeth. So they are interdigitated at a maximum level. And so it says nothing about where the jaw's positioned or anything like that, the lower jaw. It's just all about maximum intercuspation is about, it's a tooth, how the teeth interdigitate maximally.
And so in that position, you could be ignoring a problem with the condyle.
Yes. So MIP, or maximum intercuspation position, is where the mandible is located. The condyle, the position of the mandible, is located in that in MI. So when the teeth are maximally interdigitated, where's the mandible? So that's the position. That's MIP. Okay. And those are two. One is looking at teeth. The other one's looking at where the jaw is.
Gotcha. And the now centric relation is putting the priority on the condyle being in optimal position. Yes?
Yeah, that's anatomically driven position. So that's like, that's basically the structure of the mandible and how it relates to the infratemporal fossa. So it's where it's defined as the uppermost anteriormost position of the condyle. So it has like a word definition, but it's used in dentistry. It's used as a repeatable position. It's been kind of like it's been studied quite well, and there's a lot of evidence to show that MI or that CR is a position to restore your patient to, because it's repeatable. So when we're doing large cases, we need to find a 0 point at where, so we don't get lost, because the stomatognathic system is extremely complex. It's a very, very complex joint. And so we need a reference point at which we can always go back to, so that we can rebuild a patient as consistently as possible. And this comes out to what we call a treatment position. So the treatment position is that repeatable, comfortable place where you can then rebuild a patient to. And so that's, I think that concept, is whether you want it to be CR or MI, sometimes that works just MIP, sometimes that works fine, but you need to establish a treatment position for your patient. Anytime you're doing like a full mouth rehabilitation in any tooth-borne or on implants, you definitely need to know where that jaw position is going to be, and that's clinically determined.
Absolutely. And then centric occlusion, just to make sure we're all on the same page, the condyle's in position, and it's the first contact point of where those teeth start to touch, right?
Yeah, that has to do with, that's a position kind of point. So that's where the mandible's located when the teeth first make this initial contact. And that's called centric occlusion. and then there's a little bit of muscle activity, and then we slide into MIP or MI, and so there's a little bit of muscle activity to get those teeth to interdigitate, and so MI and CO are often not coincident, so they don't occur at the same space in Posult's envelope of function. And so the goal when you're rebuilding somebody's, again, you want to find that treatment position. So our goal at the end of treatment is that where we have MI and CO coincident. So that's
take
the mandible from the same position.
In an example of like a class 3 like underbite, MI and CO are way apart, right?
Yeah. Typically in class 2 for sure. Class 2 is they are very, very classic for this. So they usually have some sort of habitual forward kind of reference for how they get their teeth together. I'm definitely in class 2 patients. And so what you'll find is when you take all their teeth out, you'll get they're back in, they need to go back somewhere. And so when they power their muscles, they end up here. They end up more in a CR type of situation. And so that class 2 patients can be more challenging.
Well, let's jump into a case. And, Daniel, you've designed thousands of cases, a lot of full mouth, a lot of all on X, and, doctors give you bites and then they ask you to, mount it and sometimes open it. And so just wanted you to show us the process of what you commonly get, what those common requests are. And then let's talk about, Daniel, from your perspective as a designer, what are your, concerns about opening the bite? And then Dr. Sven, you'll share after that what you do.
Yeah. So one of the biggest, in my opinion, as I've tried to teach some doctors how to do this, with those doctors that have been the most successful, one of the things that we come into, we get together on this point is that the occlusion is a clinical decision, and it is something that the doctor needs to capture from the very beginning. And like Dr. Sven is saying, if the doctor takes the time to capture that as perfectly as possible, then we both have a 0.0 that we can always go back to, and everything from then on is going to be referred back to this bite. Now, the problem that we run into is that because technology makes all of this process look so accessible, is that we don't have to capture as much information. And in some cases, that actually does apply because technology allows us to fix a lot of problems. But one of the biggest things that I run into is when doctors say, hey, everything looks great, but the bite is collapsed. Let's go ahead and open the bite. Okay.
Why don't you show us?
Yeah. So this is what starts to happen. So this is, we're both sharing the same exact case. And so Dr. Sven will show you the aftermath of all this. But this case has just been let's call it a digital bone reduction, not based on any objective data. Have I created this? Now, the rule of thumb is that in this type of situation, what I'm trying to get is about 30 millimeters of prosthetic space, because each arch should be about 15 millimeters, right? Thickness, like for full contour zirconia, is kind of what we want to get. So right now, this is not enough space to create a structure that I'll be comfortable saying, yeah, this is going to last a long time, because at best, I'm going to get about 7.5 millimeters out of each arch. That's very, very thin. Okay, so I'm either going to make the structure extremely thick, buccolingually, which is going to impinge on the tongue space and all that. So this might be a problem. But let's put that aside for now. This is what I'm sent, and the doctor says, let's open the bite 3 millimeters or however much it is. Now, because I have no objective data at all, but the intraoral scans, all I am left with is to open the articulator. And there's going to be a bunch more data that is going to show up here, and I need you to ignore that as I go through this process. But all of the data that I have to do the alignment is this. Dr. Sven had already mounted this, so that's why it's in the correct position, the articulator. However, typically, this will show up somewhere else, like over here, and completely unrelated. So the only thing I have to use if I want to do the automatic alignment is to find these points that the software is asking for. So it asks for an incisal point, and then it wants a point on the molar, on the left molar. But okay, so sorry, the left molar. But then when it asks for the right molar, I'm not going to have anything. And so I'm going to have to now base it off of the canines because it's what I have on both sides. Now, here is a problem in of itself. Where do I put this point? Do I put it at the wear facet? Do I put it in where the contact should be? So I just get to place these points where I think they should go. And then I tell the software, perform alignment. And it just makes it flat against this occlusal plane that the software is giving me. Now, please understand that this is 100% a guess of where these scans should be in relationship to the articulator.
It's an average, right?
No, sure. We can call it an average.
Yeah.
But I think it's even more off than that. And so
Yeah, it's not a problem with exocad. It's just a problem of the lack of having relationship to the condyle data.
Correct. For those people who may watch this video who are not as familiar with the digital process, it's as if you gave me two models and told me mount them in an articulator. Well, they can go in all sorts of different positions. They could be tilted this way. It could be higher, lower. It could be further back in the hinge. It could be anywhere on this space. And what you're asking me is, why don't you just go ahead and guess? And I can make an educated guess, but it is a guess nonetheless. And at least as a designer, what happens to me is once you ask me to guess, if I guess wrong, when I guess wrong, then the problem is going to be shifted back to me.
Well, let's talk about this. Dr. Sven, what potential clinical problems could occur if Daniel's mounting is way off, right? Relation to the patient, like, are we talking like maybe TMJ problems, or like what other things could happen?
Yeah. So, if the mounting's off, basically you're like Daniel was, well said, is that, we're arbitrarily putting the jaw scans in a different location. And really the reason why is like, we can use literature norms, like those mounting plates are based off of like, here's roughly where it should be, but there's so much variability in humans, right? We're all built differently. My jaws are shaped different than your jaws. And so the odds are highly likely that you are going to be off. We're all different. So the odds are is that an arbitrary mounting is not going to work as far as if you are changing the vertical dimension of occlusion. If you're opening or closing the articulator, things are going to be off. Now, if you are just designing from that position and we're not making any major changes, then we can rely on how we then we can rely on our occlusal scheme to guide the mandible. And so with fixed prostheses, like we're doing like full arch case in this case. So what we're doing is we're relying on our mutually protected occlusal scheme. That means that anterior guidance, and we're trying to eliminate any kind of occlusal interferences on the posterior. So as long as our angles are steeper than what's in the back, then it works, right? Arbitrary mounting can work, but when you get into like denture occlusion and things like and removable occlusal schemes, and then you need to be much more accurate. And
so why don't you show us your strategy of how you do that? Yeah. Share your screen and show us the case that we're looking at here, and just talk us through your workflow, what you do, why you do it, and then we'll end with how it differs from Daniel's bite.
Right. So what I do with every case, when I know I'm going to do a big, like a full mouth rehab, right? So I start with pre-op scans, and let's get rid of all this stuff here. So I start with my pre-op scans, and then I agree with you, Daniel, that the amount of reduction here is just, this is just kind of arbitrary to make space for a wax up, but this is all done by bone. You know, we've got to, how much are we going to reduce the bone and everything. And so I got these scans, right? And now I have to articulate them. And what I'm doing at the very beginning, I'm setting myself up for success here, because I'm also, the extra data that I'm including here are individually segmented jaws from the cone beam CT. Okay. And so I'm adding these in before I mount the case. And this gives me, one, it's diagnostic. One is I can look, it's like, you know, is that pretty close to, you know, is this some kind of weird, you know, button? Like are the condyles seated in the box? You know, that's one thing I want to know right off the bat. Because if I mount this case going forward and I design everything going forward, then when it comes to my digital conversion, and this, let's say this condyle is way down here, and this happens to anybody, this could happen to anybody, then I know that my bite's going to be off when I do the digital conversion, because I didn't have a good bite to begin with, right? And so I do this for diagnostic reasons, but also I set the goal for here is to have a reference, a 0 point from which we can always go back and forth. You know, when I do the digital conversion, I want to move everything back into this wax up coordinate system. That's the goal, because that's where the wax up lives. It lives here. And so when I mount the case, the one is I've got these reference planes. So basically, when I mount this case, I add these reference planes and also the jaw, right? And so we can make this articulator go away, and then we can add our planes here. And I'm looking for the center of rotation of this condyle. And so I'm looking kind of like right in the middle of the condyle where it's gonna hinge at. And so now what I'm doing is I'm locating the orienting the patient's skull and the jaws according to the photos, and also you know, mounting it properly on the articulator. So this is the lower border of the orbit, and then this is the hinge axis. So this is an approximation of the Frankfurt horizontal plane, which is an anthropologic norm that was set up like in the early 20th century. And so this is how anthropologists look at faces. But really that plane is the upper border of the extraoral meatus. So this is the ear canal. And so I'm a little off, but my goal here is to get this center. Like I want to get this centered. So my photos might be slightly off, but the goal here with mounting is we want to get the lower border of the orbit, and we want to find that hinge axis. And so that's how I set up any kind of complex reconstruction.
So if a doctor has a CBCT,
Right.
obviously you would highly recommend they follow this protocol. If they do not have a CBCT, what could they do as an alternative to get an accurate bite opening for Daniel to design?
So there are some digital Facebook apparatus out there. You know, there's jaw motion tracking, but if you're doing it, this is a full arch case. If you're doing a full arch case, you should be taking a CBCT. And I would highly recommend for full arch cases, you should get a large field of view CBCT because we're placing implants in the zygomatic arch. We're routinely placing implants in the pterygoid, and utilizing pterygoid implants for remote anchorage. So this is very, very common data that most or all clinicians really should be taking before they embark on a full arch implant case. So yeah.
And if I may, in case that you're in this weird situation where you don't have any way of capturing this type of data, then take the time to capture the bite correctly yourself. So if the bite needs to be open, you open the bite, because
Yeah.
If you ask me to do it now with my mounting, which is a
Right.
guess, then I am most likely going to open that wrong. And
Yeah.
so you can take your leaf gauges, you can feel for the condyles, you can see where CO would be, and then scan the patient or capture that bite before you send it in. And then that way we can say that your guess is much more accurate than mine, because mine is completely arbitrary. You at least have the patient there. You can move around and figure out where his jaw should go. And so that way you end up doing the part of the process that needs to be done on your end of things.
Absolutely. Couldn't agree with you more, because you know that even this looks pretty accurate, but there's still going to be a little bit error. This all comes down, there's errors in everything, right? Nothing's perfect. And so even this, even all, even what I've done here, it's way more accurate, and I can pretty confidently open and close a bite here. So it means less iterations clinically for me. But still the proper thing to do would be to open and scan at that new vertical. And so I think that regardless, even if you go through this step, you should still be doing that. And that's a workaround that is a good idea, and it's up to the clinician to determine where that the mandible is going to be at that treatment position, like where it's up to the clinician to capture that for the technician. We don't work magic, we can't do magic, and we are absolutely confined to the data that you give us. That's our obligation to you as a clinician, is that, hey, you give us data and we will make it to the data that you give us. That's our duty and responsibility to you. And so I think the point here is that for me, at least, it gives me a lot of comfort when I start out with a lot of information about the patient. So another thing that you'll notice too is I'm fairly close to the on my wax up. I'm pretty close. I'm not like way far out. I'm not way too in as far as like where I'm putting my setups too, because also you can talk about neutral zone and where the teeth naturally are going to be. In some cases, we're going to have to guess, but like with lip biting and things like that, I'm trying to stick pretty close to there. And not to diverge a little bit, but neutral zone is another important concept of your overall setup. Go ahead, Rob.
Sorry, let me interject. Going off of what Doctor was saying, which I think is key. So the setup that he's done is not only guided by his knowledge and his interaction with the patient, but for somebody like me who's designing remotely, it will be very, very important for him to say, for example, those centrals, those upper centrals are too far out, and I want you to bring them in. And so by capturing the pre-op scans gives me a reference point, and then you can guide my design through that reference point. So I don't like how wide the arch is. I want it wider. I want it narrower. The teeth are too flared out. Tuck him in, whatever it is. Too much lip support, too little lip support. It's all going to be based off of that mesh that he's showing there. And then I can the ideal situation is I have enough data, number one, and number two, enough instructions for me to get my design to be as close as to your ideal the first iteration. And if we both are communicating in such a way, then the likelihood of you having to have 3, 4, 6 visits with your patient diminishes. And now you can have a patient go home happy with their finals 2, 3 visits in, and that's it, which would be the goal. But if the doctor does not communicate correctly or doesn't capture enough data, then you're going to see this patient 5, 6 times, and now he's going to be frustrated, and everybody's going to be not on the best behavior because everybody's frustrated. So there's so much heartache and so much suffering that could be saved or that could be avoided if we just take a little bit longer time on the clinical side of things and capture data and pass on information and instruction as clearly as possible. So it's awesome what Dr. Sven is doing.
Yeah. Thank you. I think and we find that too is like the clearer the instructions are, like say lip biting or cheek biting or something like that, the more information I can give you, Daniel, the more power you have, right? Like I can say, okay, I want you to move, like either shrink move the occlusal plane in, or the arch form in, or the anterior teeth need to come in this amount. And you got to be as descriptive as possible in order to empower, your designers to do the job that you need them to do. So this is like communication. We're all a team, and we're all trying to work this problems, work through problems. But clinical findings are an opportunity to make those design changes, and errors will occur, where nobody's perfect. And so your power as a clinician is how well you can prescribe prescribe the changes that you need to have made.
Yeah.
And that's the key.
Dr. Sven, I noticed your mounting goes, it's angled and goes deeper into the occlusal plane than Daniel's mounting did. Why is that?
So there's camper's plane, right? So there is the occlusal plane typically is we call it camper's plane. A lot of setups like the removable are set up as camper's plane. And that's why we use Frankfurt horizontal plane as our anthropologic norm of how we look at a face. Okay, and when you take your photographs, you want to capture this Frankfurt horizontal plane. Camper's plane is about 7 degrees off of that. Okay, and typically occlusal planes are going to have some sort of cant, and I bet you this is close to maybe 7 to 10 degrees off of that plane, and so that is normal. And when you look at a face, you see that you rarely see occlusal planes that are flat. Those are typically going to be artificial, and they're going to be more of a kind of a poorly made denture type of look. And so without accurate photos, how are you going to convey? How would the designer know, where things are going to be located? If you got photos like this, canted out, or if things aren't, if you haven't captured in your photographs, the correct orientation, then it's going to be really hard to do that setup. Then everything is arbitrary.
But that degree, though, that I don't know, what camper's plane is, the degree that is sort of tilting down.
Yeah.
In the absence of this condyle position information, Daniel has no reference of what that angle actually is supposed to be, right?
Yeah. The only reference that he has is the photos, right? So if you take photos that are straight on and you're capturing this Frankfurt horizontal, then you've got your 0, because we can add some photos in. And this one is not like perfect, but they're relatively orthogonal, to or 90 degrees to each other. Then from there you can make another plane and create a camper's plane. And then also when you just look at it, right? Teeth are not supposed to go flat straight across. Teeth go up and curve. That's what it's supposed to look like. And if you look at most human beings, they have this look, this nice, arc. So that's kind of, when you want to set up a case, that's what we're looking for.
So can you show Daniel's mounting that he was able to do without the condyle position information, and how it differs from your mounting? Right.
And so this is how Daniel mounted the case. And this is like basically, the midline is on, right? But or the midline is close, but there's a cant there's a cant. So if he, basically there's a potential for him to build a canted upper, right? So the max, when you're framing when you're doing smile design and facially generated treatment planning, is all based on how you mount the upper to a photo. It's all about like the maxilla and the photo lining up. The lower jaw is just, it's going to be moving around. You just got to figure out how to interdigitate those accurately. But aesthetics and stuff all comes from mounting the maxilla, the teeth to the maxilla, and then mounting those properly so you can look at the face correctly. And facial scanners they don't provide you as precise information, I feel, than 2D photos. Like I can absolutely set a 2D photo up as accurately, so I feel like I'm looking at it properly. I don't know if you feel that way, Daniel, but
yeah, I actually I don't see the use of a face scan, and
right.
maybe people are going to lynch me for this, but I don't feel like it adds any better information or any information that's better that I can get than what I can get from a good 2D image.
Yeah.
Perhaps the only way that it can help is by showing proper lip support, but it really depends on how well the scanner can actually capture the smile. And for the most part, in my experience, that's like 1 out of every 100 scans you actually see the teeth correctly. Otherwise, it kind of like meshes the shape of the teeth weirdly, and so you can't even properly align your scans to it. So it's I think that they add more problems than they solve, but I think is a great selling point for the doctor. Like, look, I'm high-tech doctor. Look, I can scan your face and all that, but yeah, as a designer, I don't see the benefit of a face scan personally.
Yeah. From an analytic, like just from a straight up analytic point of view, I agree with you too. It's kind of it's semi useful, but even with the lip support thing, it doesn't capture the inside, which is like where things are going to be interacting. And so I think you have to go off of what you have, like what knowledge you have about the patient. And again, that's a clinical decision. Like, hey, this is where I want my 8 and 9 to be. Those are really clinically determined.
So,
go ahead.
I would much prefer a good 2D image, a pre-op scan in thorough RX than a face scan any day of the week, twice on Sunday.
Yeah.
And leaf gauges if they're going to open the bite.
Absolutely.
Yes. All day, man. That's the way to do it.
So, Dr. Sven, what problems could occur clinically and impacting the patient if you were to proceed with treating this patient with Daniel's mounting?
Yeah. So one thing that we will see here, let's say we open, in this scenario, we're opening the bite. Let's say, it's too close. Her facial third, she's smashed up down here. And also like closest speaking space, when you say Mississippi 66, we're looking for about 1 millimeter of space in the premolars. And so that's another indication of like, hey, is this patient too open or too close? So if you've got like a mile between, your premolars, 66, right? Then you can open this patient up more, okay? So that's another little clinical guide that prosthodontists use to determine this vertical dimension. So in this case, we have 2 different mountings, right? So we've got the green is the one that's been mounted according to the patient's CBCT, or where we think the hinge axis is located. And then we've got this arbitrary mounting. So let's say we open the bite 3 millimeters, okay? And then what we're going to do is you notice that these molars are further away from this hinge axis than the green ones. And so what we're going to do is we're going to make these taller so that they interact, and we're going to make these taller like the green ones. Okay. So we're going to make these taller, and then we're going to make the white ones taller. So what we're going to find is when the patient bites down, these are going to actually hit, these were opened, they're further away, and these are going to hit first because they are further away. So the further you go from a circle from here to here on this arc, the more the movement, right? And we know this because of the pin rule. Like if you open the articulator 3 millimeters at the pin, it's what was it, 1 millimeter at the molars. Okay. And so we open this patient up just slightly more at the white. And so when we put this back in the white, let's say we build this, we put this back into the patient, it's going to be heavier here. It's going to be heavier in the back.
So they're going to slight anterior open bite.
Mm-hmm. Yeah, and that's typically what we find is like if you're that this is where you're gonna the occlusion is gonna be slightly off, and you're gonna need more adjustments, and maybe a lot more, and then also the consequences of also having a cant too. So we also have to deal with a cant now, because this is the patient's face. We already saw what the patient's face was like, right? So now we have a canted face as well. So potentially this could be off.
So solve it with the CBCT or leaf gauges when you want to open the bite. Otherwise, you might introduce some other problems. So could we introduce like TMJ pain or other types of things? Like, how significant of a problem could this create? Is it mildly significant or severely significant based upon the differences here in these mountings?
So TMD is pretty complex, and so it could be related. You could get muscle strain if the patient is trying, or if you put them in your pre-op records. If you were off on the bite in your pre-op records, and you are telling them to, and they're trying to get into that space, and they're having to fire a lot of muscles to get into that bite, because of some errors in the pre-op, then basically you could, introduce some muscle strain, intercapsular like issues that may or may not occur. I would say that certainly TMD could arise from being off with your bite, but there's also other things too involved in TMD.
As a designer, the problem that I'm going to see from this is how many iterations of the case we're going to have to do.
Yes.
So put aside what can happen to the patient anatomically. It's just the fact that now your patient is mad because now he has to come back and see you multiple times. Right. And then like the whole relationship gets strained between doctor and patient, and also doctor and lab, because of the problems that this is going to create. That from a designer standpoint, I understand Dr. Sven has got to look at the anatomy of the patient, but I look at it as a relationship problem. We're shoving a wedge here that is going to be is going to cause strain down the road. So that's what I'm looking out for.
Yeah, and the thing is that like on your side, like you just all you can do is work with the data that you're given, right? And then if the doctor on the clinician side, if they are confused about why the bite would be off, like why are things off, it's kind of amazes me how we don't look inward sometimes, about like what could have been the cause, like, oh, maybe I missed something, or maybe, and so we all have to kind of like dive deep and figure out, okay, what could be the cause here. And if you don't know what's going on, then that's where problems and conflicts arise, is when there's nobody understands exactly what's going on, with why things are off and what to do about it.
Well said.
Yeah.
Dr. Sven, you have any advice for Daniel related to best practices in managing occlusion without this, condyle mounting situation here?
Yeah, one is yes. So one is tell the patient. So one on the clinician side, what I tell my patients is I'm going to make my best guess. Okay, and that's the language that I use, and I also tell them that this is a journey. Okay, so we are going to iteratively figure this out together. When I have a removable patient that I know has a habitual like bite and things like that, I tell them ahead of time, and you should really tell patients ahead of time that this is a journey. I'm going to make my best guess as far as where your bite's going to be, and we may be off a little bit, but what we're going to do is we're going to figure it out together. So patient management is key with all of these, and also so you kind of anchor your patient's expectations that, hey, we're going to figure this out in a couple of iterations. It is super naive. It is very naive to believe that every single case you're going to nail it. Every case. That's not going to happen. It's never going to happen.
If I'm a patient in the chair and I have high expectations of your expertise, I
Right.
might be curious and say, why is this a journey? Why do we have to go through so many iterations, Doc?
What I tell them ahead of time is we may have to do that. And the reason why is because you are complex. You know, is because your anatomy, the way your jaw functions, is very complex, and we don't always capture everything perfectly. And those are the people that I work with.
So from what Dr. Sven is saying is 100% correct. You need to manage your patient's expectations. This whole, like, tomorrow you have your finals. I mean, there will be cases where you'll be able to do that,
Sure.
but the likelihood of that happening is not 100%. So you have to manage the patient's expectations, and you also have to you have to manage your own expectations as well.
Yeah.
So that you are open to the possibility that this may not work out perfectly the first time around, and we have to figure this out together, as Dr. Sven was saying. So yeah, that is absolutely key. So that, because I've had patients, or I've had doctors send me, all the patients going to a big wedding in a week, and we're just going to do this double arch surgery today. And it's like, all right, good luck. You know, hopefully we get it.
Yeah.
But if you tell the patient, yeah, you'll be able to smile huge and beautiful for the wedding, and then you don't hit that mark, then there you go. There goes your reputation. Why will you put yourself in that situation?
Yeah. Yeah. And I mean, exactly there's always an opportunity for things to go wrong. This treatment is complex. And that what is the kind of the thing that's kind of deceiving about it is that some cases go so easy. Like some cases, I tend to get the hard ones, but like a lot of cases tend to go really easy. Just MIP capture, it's going to be repeatable. They've got enough posterior stops. There's not a lot of interferences when they bite down. I mean, the condyles seated, and they're comfortable. And so those cases go deceivingly smoothly, and it happens it can happen quite a bit. They come in waves, but like there are some patients where they are going to work you big time. I think my record is like six prototypes to nail everything. And so it's all about patient management and walking that journey with them. As a clinician, that's your responsibility.
And as we were talking about earlier, Rob, on the technical side of things, when these surgeries happen, because the patient looks all feedback mechanism to know where their jaw is going to go, they need to relearn that. And so that can take, just like anyone going through physical therapy, you might get better in a week, and then this guy might take 2 years for the same injury. And so it's kind of the same thing. And so that's part of the, you may not want to say that directly to the patient, or you might, so that you can manage the expectation. Say, look, you pretty much are going to relearn how to close your mouth. You'll forget all of that. And so if you prepare the patient in a way that you find fruitful, then you shouldn't have a patient that gets frustrated after the second iteration, because this is a possibility.
Yeah. And so the patient coaching is the key. You are a coach as well, because you're taking away a whole bunch of stimulus that they used to have, of how to get their teeth together. And so you're removing all that. And so now you coach them into kind of how to bite. So that's part of I take a mirror and we'll practice. Let's practice 10 minutes a day. And we'll kind of work on that. Is that comfortable? Is that good? And so some patients are that challenging. So they tend to, the athletic kind of patients that just naturally build up muscle memories, like some of them are just going to take to it really easy, but some aren't. It's going to be harder for them to build those muscle memories of like, oh yeah, this is how my teeth go together again, and so that's a very good point, Daniel. Very, very good point.
Sven, any recommendation on so if Daniel does have a case and he's mounting it and the occlusal, can you open the bite by like a 0.5 millimeter or 1 millimeter and be pretty reliable? I mean, obviously the more you open it, the error is going to sort of compound.
Yes.
but can you get away with some smaller openings and
Yeah.
be close to okay type thing?
Yeah. So we're talking about the range of adjustability, right?
Yeah.
So we want to, I consider if it's, less than that, my goal is 200 microns. I mean, that's a tough goal because that's not a lot of adjusting. So in my errors, that's what I'm looking for. I want just a little dusting here and there, to get everything dialed in. But if I get more, I get pissy if I'm more than a 0.5 millimeter. Like if I start grinding things and I'm having to do a ton, to get MIP and CO to coincide, then I'm getting a little like, or whatever my treatment position is, I'm getting a little grumpy. And so the smaller amounts of opening, the smaller changes, the less error you're going to get in your arbitrary mounting, right? Because we've got, it's a further away, but we're just opening it a tiny bit, like a millimeter at the pin is nothing,
Right.
So that's not going to be a significant amount of a change.
Any rule of thumb? I know that we've talked about this before on, if you're going to arbitrarily open the bite digitally more than X, then you should really use leaf gauges.
Yeah, and I'd say if you're gonna open anything more than like 3 millimeters at the incisors, that's quite a bit at the pin. So if I would say 4 at the pin and less is probably meh. It's okay, but I personally would go with some sort of leaf gauge, have them go forward, back, tap, 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 and then squeeze a little bit, and make sure there's no pain. Like when they squeeze on that leaf gauge, make sure there's no intercapsular pain, like inflammation.
And then from my end, I will say, always use a leaf gauge.
Yeah,
always. Just it is much more reliable again than what I'm going to be able to guess.
100%.
So let's just
let's do that.
Yeah, and not to beat a dead horse, but I try to separate things on what I consider to be clinical decisions and then technical decisions.
Yeah,
and then the technician should not be making clinical decisions,
never,
or vice versa. And so if we each take full responsibility of our part, then you shouldn't be asking me to open a bite, and I shouldn't be asking you what material should I use type deal. Like we can both use our expertise and come together for an optimal result, but everyone doing what they're supposed to be doing.
Yep. Yeah. And looking at this screen, this is like if this is a great practice, like for a clinician. So if I have a designer doing a wax up, I will go ahead and remount the case like this. So I'm looking for, okay, what kind of stuff am I looking at here? Where are my errors going to be as far as like how I captured the bite? And then I always have like this common reference zone, reference place. So I think this is kind of this is a clinical procedure here, is mounting the case. I mean, we used to do that like in analog. The clinician typically mounted the case with an old school face bow, and that's what we did before we sent it off to the lab. Back in the day, that's what we did.
Now you're just doing it all digitally.
Now we're doing it digitally.
Gonna reduce your error even more. Daniel, any more questions just on occlusion for Dr. Sven?
I mean, we can be here for hours.
Yeah,
I think maybe we should do like a different episode where we get like deep into like technicalities of occlusion.
Right.
And but I mean, I'd rather not get into it right now, just because it'll stretch out the conversation quite a bit. But
we've got this slope, we've got these slopes, we've got all kinds of geometry here to dive into, man.
Well, as we wrap it up, then, Dr. Sven, do you have a access to a really complex case that you treated successfully, where when you mounted it, you're like, oh boy, this one's going to be challenging? Something that you could show us of like a difficult case that you solved with this type of mounting?
I'll show you a case that so this is an existing, we are going to end up replacing this. This is an existing zirconia. This was mounted using, I think it was that dental segmentator with the three, so it's produces a nice segmentation, and so this is the wax up. But what's missing here is the right condylar information. So I'm looking at it. This is what I got from the surgeon, and so I'm looking at it, and I have no idea. So I was like, okay, it looks pretty good. And this was a mistake on my side, is I didn't catch the kind of the fact that he was going down and to the left in order to get his teeth together. So I'll have to send you some videos of the fact that he was, so if his condyl's out, right? So he had to do some sort of MIP weird thing to get his teeth together. So when I did the digital conversion, and then when I delivered the case, he was high on the right side. And so what I did is I just got the wheel out and I started grinding, right? And so I ground it down to MIP. So I had to do some significant adjustments to get him close. I'll send you the videos, okay? And maybe you can include those in the podcast. And then what I did is so I got him into MIP. So then I took it out. I did a 360 scan, because what did I not adjust? The bottom and the lingual, right? So I have that geometry preserved. And we mill our provisionals, so they're pretty, they're pretty accurate. Even 3D printed provisionals are going to be pretty accurate. And so then I put it back in, and then I scanned that bite. Actually, I scanned it before I did the adjustment, and that would give me, better alignment. But you could adjust and just do a 360. Then I put it back in, and then I scanned the bite. And then I go back into my digital conversion, and then just shift things, and then just realign, or basically realign that provisional to the new bite. And then that's how I pivoted. So, nice. So this has, sometimes you don't, all of us make, this is a case where I missed it, and
so then you just knew you were going to have some, so you knew. So you do a lot of your own designs, right? So
sure.
It's not the designer's fault then, for sure. And you're going to have to do some heavy grinding in the mouth to find the true position.
Yep. And so it happens, man. It happens to the best of us. And so there's a lot of pros colleagues that I keep, sometimes we just miss it, and it's going to happen. If you do it enough, you're going to make enough mistakes. And so for me, this was a good lesson of like, and I also had the skill to pivot, quickly pivot. So I record when the bite is off, you want to scan that provisional, you want to scan the parts that haven't changed. And that's what you're going to use to realign to get your bite correct. So I'll show you the presentation, like how he presented in the delivery, what I did immediately to get him comfortable, and then I'll show you the pivot, the provisional that I delivered, within a few days, and reinserted the bites, and nailed.
I'd love to walk through that whole case with you and just do another recording. That sounds like a good.
Please invite me.
Yeah, man. Yeah, always. Yeah. So I'll send you. I'll text you that right now, and we'll upload it. We'll share it with you, Daniel, too, so we can kind of like look at it.
Awesome.
So in closing, Daniel, any final comments or remarks? Anything we haven't covered?
No, I think we were pretty thorough. I mean, just as a fadeaway shot, just have grace for each other as you're working through this between clinician and technician. You both are going to make mistakes, like Dr. Sven said, but you both, with the knowledge you both have, there should be enough for you to pivot and be able to still give the patient what they need. But have grace that if you make a mistake, it is not that you are incompetent or anything like that. It's just, we made a mistake, so let's fix it type deal.
Yeah, and absolutely, man.
And I assume you use CBCT on 100% of your full arch cases then? Yeah,
absolutely. Even though I'm not even the surgeon, we're going to collect as much anatomical data as we can. So we're screening for pathology. So we're looking at the overall health too. So we're looking for pathology. We're also using that for treatment planning, like where are the implants going to go, and then two, for me also, I use it as a check. Check my records, mount the case properly. I'm getting as much information as I can, so I have as much control and predictability as possible.
Awesome. I love
That's
it.
it.
Well, thanks for sharing.
All
This
right.
was fun. We'll do it again.
Absolutely.
A pleasure,
See you
guys.
guys.
Yeah.